Hi, everyone. A new week starts, and I'm really excited to talk about roles and scope of practice for RPNs and RNs in Ontario. But I will say that sometimes it's a little bit of hard going only because there's a need to be really precise, and it's a challenge to be precise without being tedious. So let's hope I make the mark on that and hope that we can just get our heads around what that looks like and feels like for us, for all of us working in this province. So let's start. You're going to hear more about this next term when you take the Interprofessional Healthcare Teams course. But it's important to understand sort of how roles fit into healthcare practice, and nursing practice. So a role falls within sort of a basic definitions of, that describe a set of expected behaviors. So how we behave, but also the responsibilities that we carry within our role. And so it's what we say and also what we do. And there's a variety of ways that we can own a role. So it can be an ascribed role. So it's just based on an intrinsic characteristic. So for example, I'm a mother. If I have had a child and I continue with that child to raise that child, I might be, I might also call myself a mother if I had a child and gave that child up for adoption. I might also call myself a mother if I adopted a child. Do you see how there's an ascribed role? All three of those, I would define all three of those as mothers. I wouldn't say I'm an adoptive mother. I would just say I'm a mother. Or I wouldn't say I had a child but I gave it away for adoption. I still would say I bore a child and I feel I am a mother to that child, even though I didn't raise that child. Do you see how an ascribed role, it should be something that's obvious, but it isn't always. And that's what we always have to pay attention to in nursing. I'm an adult is an easier one. Or well, you know, here again, let's look at gender. Gender is very fluid now. So we used to say you're ascribed to a role as a male or a female, but now we know that many people are non-binary, or they may be have different gender identities. So it's not just male and female at all, is it? It's very fluid. So it's important that when we think of ascribed roles, so roles that you can just identify by a certain characteristic, we don't make assumptions. It's so important we don't make assumptions, and that we actually ask people to define for us what that role is. There's also roles that we achieve, right? And so that could be a really good example for all of us is our registration. So I became a registered nurse. All of you have become registered practical nurses, and very shortly to become registered nurses. Many of us have achieved other things. You can also be assigned a role, right? So somebody is assigned a specific role. That could be by a job title. I'm the president of the university. No, I'm not, but you get the idea. And then it's important that we recognize within the context of practice, intra-professional practice, that's nurse and nurse, RN to RN, RPN to RPN, RPN and RN, all of those kinds of role intersections, and interprofessional. So intra-professional is within our profession. And if you remember, CNO says we are one profession with 3 designations, RNEC or nurse practitioner, RN, and RPN. So one profession, 3 different roles. So it's important that we recognize the significance of roles within the context of that inter and intra-professional practice. Inter-professional practice is practice between different professionals as we interact with the physician, the physiotherapist, the occupational therapist, and on it goes. And it's really critical that we understand that the overall effectiveness and the productivity of our team is really essentially affected by how well we are able to enact our role, how well we're able to understand our own role and others' roles and enact those roles or take on those roles. And because there are so many professionals, when you think about work, think about how many people are involved in the care of one client. There may be dietitian, social worker, discharge planner, RN, RPN, physiotherapist, occupational therapist. Let's take my mom. She's in the hospital right now. So she's being cared for by a physician. She has RNs and RPNs looking after her. She has a geriatric consult coming up. She has a physiotherapy consult, an occupational therapy consult. When she first went to the ER, the social worker called me as opposed to the doctor calling me. Look at all those professionals in the care of one client. right? And so that idea of interprofessional practice is so critical because there are so many members of the team, and each one of those members is dealing with their own understanding of their own role and the enactment of their own role in the context of all of us working collaboratively together and coming in and out of a variety of groups. So for example, my mom's going to be hopefully in the hospital for a short time. She has some urosepsis, which is sort of recurrent for her. But let's say she's in the hospital for 5 days. The physiotherapist may come and see her a few times or do an assessment, or even more likely the occupational therapist may do an assessment. But we can't imagine that person has an ongoing role. So what I would imagine, and you guys tell me if I'm wrong, an occupational therapist would call me, ask me if we have grab bars, what kind of assistive devices do we have at home, are there any hazard risks, do we want an occupational therapist to come to our home to check that it's safe, things like that. But the occupational therapist in this situation, my mom who's admitted with urosepsis and some delirium associated with that, occupational therapist is probably not likely to lead the team. On the other hand, there may be situations where that person does. So we come in and out of teams and we enact our role in different ways. And that's really critical too. Important to recognize, and again, we'll talk a lot more about this next term, but it's important to recognize the challenges that we experience. And I bet you guys have experienced many of them. So first we look at role conflict. So that's when you're having a competition or a conflicting set of expectations or demands. So I may think it's my job. Let's take a simple thing. If we are going to ambulate a patient, let's say my mom, we're going to ambulate my mom. She's admitted to the hospital. She's got terrible pulmonary fibrosis. She uses a walker to get around. She's on HOMO 2, and we need to get her up and going because with this delirium and her urosepsis, she hasn't been walking for several days, and we know you lose functional capacity at a rate of about 10% per day, right? So it's really critical to get her up. Who on the team could actually support the process of getting her up to mobilize? Okay, take 5 seconds, name 5 roles. Okay, let's think. For sure the RN, the RPN, PSW, the physiotherapist, potentially an occupational therapist may be part of that. There are numerous people can take part in that activity. So how do you decide who is the best person? Sometimes it's who's there in the moment and what has to be done. So for example, if my mom has to go to the bathroom, and again, you guys may experience something entirely different. What I typically would have experienced is that the physiotherapist typically does not want to get my mom up to ambulate, to do an ambulation assessment by ambulating her to the bathroom. Rather, the physiotherapist would say, let me get your nurse and I'll be back later. I could be wrong, and please don't think I'm knocking physiotherapists. But do you see that? It might be what has to be done or what's the activity around ambulating, or it could be who is there at the moment, or it could be who has the most knowledge of that patient. So a lot of things come into play in that. Role confusion is when I'm not really clear about my role and/or I'm not really clear about your role. It's critical that we understand not only our own role, so what do I do as an RN, what do you do as an RPN, soon to be RN, and what does every other member of the team do? I will say, and I apologize for having this gap, recognizing it and not having filled it. I don't think I have the best clarity about what an OT does. I know some of the things, I don't know all of the things. So fair enough, I have some learning to do there. Role confusion leads to a lot of chaos as we're trying to figure out who is the best person to take the lead of a situation, not the lead of care in every aspect, but the lead of a situation. And the final thing is role distance. And role distance happens when there's some internal separation, not physical separation, but some internal separation between who I am or how I think of myself, how I think of what I'm doing, and the role I'm expected to occupy. And I'll give an example, and again, maybe none of you experienced this, but a lot of new graduates, both RPN and RN, talk about this experience of feeling like a fraud at first. That I don't feel up to the job, I don't feel capable, I don't feel completely competent, and often it's that fake it till you make it mentality. I hope nobody can see that I'm really a fraud. That sense of detachment from what I am really supposed to do, and I don't really feel like I am fulfilling that role. Role distance is also important because if we are not confidently standing in our own shoes and understanding our role and fully enacting our role, then the team will break down and patient outcomes will be profoundly affected. And so here we talk about, this is a little bit of role conflict, role confusion, when this teacher is saying, I expect you all to be independent, innovative, critical thinkers who will do exactly as I say. What I would say, I hope it's not the same for you, but what I would say is when I went to nursing school, that was probably the underlying thinking process. Now, how do we figure out who looks after who and how we make that determination? Hopefully all of you know this well. I typically would make notes that are very more brief and speak to something. Here I'm actually going to clip very specifically from the CNO documentation. I'm doing that because it is essential that we be really precise. So I apologize for that, but it's just really important that we be precise, and I bet all of you know all of this, and so it will be a breeze. So what is the point of the 3-factor framework? It helps everyone. So it helps me to determine who should look after it, what kind of patients. It helps others to determine that. It helps the employer to determine what kind of staffing ratio do we need, and even at higher levels. That make that determination of how to provide safe and ethical care based on the kinds of rules that we need. And it's important that we look at the similarities and differences in knowledge base, right? And how that impacts our autonomous or independent practice. And so do you remember that College of Nurses talks about that both RNs and RPNs study common knowledge, right? So there's a lot of common knowledge between RPNs and RNs, but the RN typically studies longer and at a deeper level in many of these areas. Although, again, I'm going to say things are a little bit fluid and we are seeing some changes happen over time. It also is important that the 3-factor framework highlights the accountability we have. So it not just helps us to make decisions about who is the best person to look after that patient, it also highlights who is accountable, who is responsible, and how the organization as a whole is responsible for having the resources necessary to be able to look after our patients. It also looks, so in that respect, at the practice environment. So we look at the individual accountabilities. How am I as an individual nurse, as a professional accountable, but also how is the organization responsible for the practice environment? And how do we create situations that support us in having solid nursing assignments that allow for collaboration? And how does all of that lead to better client outcomes? So it's really important that this 3-factor framework developed by the College of Nurses is a model that allows us to really consider what are the factors that help us to determine how we can best provide care leading to the best patient outcomes. And it's not just a simple tick box, right? There's always a fluid movement between the variety of characteristics. So what's included in the 3-factor framework are some simple things, some guiding principles. So what are the basic principles of this framework? How is it constructed? What leads us to believe it's a solid framework? How does this fit in with the legal scope of nursing practice? For all of us, we need to follow the legal scope of nursing practice, and so that's really important. And where is the individual nurse's accountability? So it's not just should a RPN or an RN be able to look after this patient. It's as an individual nurse, you have to make the determination, am I able to? And where your accountability lies. All right, so that's really critical. Within that whole 3-factor framework, it tells us what is the guiding, what are the guiding principles, what led to the development, and what is the structure of the framework. It tells us how this fits with the legal scope of practice for RNs and RPNs in Ontario. It also talks about nurses' accountability. We'll talk a little bit more about all of those things. And then it goes through those 3 factors. And I bet all of you know this, but here we go. 3 factors are client factors, we'll talk about that, nurse factors, we'll talk about that, and environment factors, and we'll talk about that. Okay, so let's talk. Remember I said that any kind of model really has to give us some kind of philosophical background or guiding principles that help us to understand how this was developed. And so what the CNO has done is really give us a sense of what was the focus. And so for this 3-factor framework, the focus was on decision-making within that team, right? Within the intra-professional team. And that intra, do you remember that RN to RN, RPN to RPN, RN to RPN. So within the profession, any of those categories of nurses working together. So you could have a whole team of RNs and RPNs working together. So it's decision-making within that intra-professional team. And so CNO reminds us of some basic principles. One, that the goal of professional nursing practice is to lead to the best possible patient outcomes. All of us know that. So when we're making a decision about who is the best person to look after our clients, we're guided by this objective to lead to the best possible patient outcomes, right? That's an obvious one. I mentioned this before. RNs and RPNs, same body of knowledge, but RNs typically study longer and at a deeper level. And so as a result, RNs have to this date, and we'll talk about this more in a minute, had a greater level of autonomous practice, so independent practice. And a couple more points. One, the complexity. So how complex a client's condition may be. And there's several things that influence complexity. It's not just higher acuity. Often we think of patients in an ICU setting may be more complex. Sometimes they for sure are, but it's not just higher acuity. It's complexity in terms of multifactorial issues going on. And one of the areas of complexity may be whether the patient has a diagnosis or not. So looking after patients who have a diagnosis or who are yet to be diagnosed, and all of the other things that are associated with their care, right? That influences the nursing knowledge that's required. How complex the patient is influences how much nursing knowledge is required to care for that patient. So the more complex a client situation, the more complex a client situation, and the less stable an environment is. So an environment that's less stable would be an environment where there are not the resources I need, the supports I need to be able to ensure that I'm able to provide that care. That leads to greater consultation. So let's say I'm an RN, new RN looking after a patient. The patient requires has a little bit of complexity of care, but the environment is well supported. I have lots of resources. There's an RPN that I'm paired with today has been working on the unit for a long period of time and has a good understanding of this type of patient and has worked with this actual patient before and is able to mentor me in that situation. So even though one of the nurse factors is that I am a novice nurse, the client factor is that increasing complexity, slightly increased complexity, but also an environmental factor. I have the resources. And things could be entirely different. It could be a patient who's, again, has increased complexity. It could be that an RN is looking after that patient, or an RPN is looking after that patient, and I do not have enough environmental supports to be able to do the appropriate consultation. So are there people there that I can talk to, that I can ask questions of? So really important that there's an opportunity for consultation. If I'm not sure that I have the knowledge, the judgment, and the skill to be able to effectively look after a patient, I need to either be able to transfer that patient or undertake in consultation that will help me to, in the moment, be able to acquire either that knowledge, judgment, or skill. Sometimes it's a simple thing. Do I know how to do this? Let me review that thing. It can be quite narrow in scope, or it can be quite broad. When it's quite broad, often that's where we move to transfer of accountability to another care provider. Boy, a wall of words on this slide, but I just want to make sure we're all on the same page. Our legal scope of practice. So in Ontario, there's two laws that are important to us: the RHPA, Regulated Health Professions Act, that was from 1991, and the Nursing Act, 1991. So they're both just about 30 years old, and yet they are central to understanding our role and our scope. And it's important that we understand what the scope of practice statement is for nurses, RNs and RPNs in Ontario, and I'm going to talk about that later. And also, what are the controlled acts? What are the controlled acts that nurses are maybe authorized to do? And just as a reminder, controlled acts are activities that can be potentially harmful if performed by people who are unqualified. And so there's a list of them. I'll talk about that in a minute. But within the profession, we are able to perform those controlled acts. So the expectation is that we have the knowledge, the skill, and the judgment. And by that knowledge, skill, and judgment are authorized to perform those controlled acts. And within that regulated health profession, we can perform only the controlled acts that are outlined to our specific scope. So until now, RNs had a list of controlled acts that they could take part in, and our PNs had a different list of controlled acts, and I'm going to talk about that in a second. But so let's come back down to one more point. The scope of practice, so we all talk about scope of practice. It's important to recognize we all think I want to work to my full scope of practice, and that's a misnomer. The scope of practice is a range of activities, the full range of activities that are included within the profession. So no individual nurse is ever expected to get to take part in all of those activities across the entire range of the profession. It doesn't make sense, does it? So each one of us works to our greatest capacity within, outlined by the scope of practice, but none of us fills in the entire scope. It's all of us working together as a profession that fill in the entire scope. The scope, imagine it's like, let's imagine a huge field with a fence, and we're all in there together. So the fence gives us a framework. We stay within those boundaries, but not all of us will cross the whole field. I might just stay in one corner. I have my patch. I'm feeling great in that space. Someone else might be in a different patch. They like the sun. I like the shade. However that goes. Do you understand the point that not all of us go across the entire space? And in fact, one nurse is impossible. It's impossible for that person to cross the entire range of scope of practice. So full scope of practice is for the whole profession. All of us work to the utmost of our capacity. Now, remember I said I would talk about controlled acts, right? And this is so important. Again, we're back at 1991. That's our legislation. And here are the controlled acts in Ontario. So there is performing a prescribed procedure below the dermis or the mucous membrane, right? Below the dermis or below the mucous membrane, administering a substance by injection or inhalation, right? Somebody off the street just can't give a patient an inhalation treatment. Putting an instrument, a hand or a finger, in these various auricles. So beyond the external ear canal, beyond the point of the nasal passage where they normally narrow, beyond the larynx, beyond the opening of the urethra. So here we know it's inserting a Foley catheter or an in and out catheter, beyond the labia majora. And so again, that may be when we're doing things like assessments for a laboring mom to see how much their cervix is dilated. Maybe in, if I'm a nurse practitioner, inserting a IUD. So beyond the labia majora, beyond the anal verge, right? So beyond the anal verge, into an artificial opening in the body. So for example, into a colostomy, an ileostomy, something like that, or dispensing a drug, actually dispensing a drug and giving it to a patient, and then taking part in psychotherapy treatment. Now, look at this next statement, because I'm going to talk about it as we carry on. It says there's differences between RNs and RPNs, authority to initiate these controlled acts. So not all RPNs could initiate all of these controlled acts. And initiation means that you can autonomously decide if that procedure is necessary and perform it in the absence of an order. Now, typically in the hospital setting, you have to have an order to do everything, but this might be in a variety of different community-based settings. So most often an RN would be able to perform all of these controlled acts in the absence of an order if these procedures were required. So it is that initiation of the procedure independently. And typically the RPN was not able to initiate that independently, and in some cases not even able to do that with an order. But we've got some changes under review, and I'm not sure if any of you have heard about these, and some of them are quite controversial. So first we'll talk about RNs. We have been talking for a very long time about getting to prescribing. the goal was to have that completed by late 2019, and now we're moving into late 2020. So obviously we're behind the ball on that. And I'm not really sure the status, to be honest. So it is in the works. There's a lot of consultation that continues. So we'll see when the legislation changes about that. And additionally, to this point, there has always been a very clear mandate that nurses were prohibited from making or communicating a medical diagnosis. In this situation, that scope of practice would be expanded to include the controlled act of communicating a diagnosis in non-complex conditions, prescribing also in non-complex conditions. And there would be some very strict boundaries on this expansion of controlled acts for RNs. For RPNs, this is pretty exciting. There are a lot of changes, right? A lot of changes in the works as they're looking at controlled acts as well. CNO has just gone through a process of approving this at the board level. And so we'll see how this moves through. There is actually a lot of controversy about this. So we'll see how this moves through over the next little while, but ultimately it's up to the government to make the determination if they want to accept this change or not. CNO has approved it at the level of the board, and to change it, then the legislation will change. So changes to controlled acts for RPNs would be including irrigating, probing, debriding, and packing of a wound below the dermis or below a mucous membrane. Venipuncture in order to establish a peripheral IV and maintain its patency in a variety of circumstances that they would limit. Putting an instrument, hand, or finger beyond the individual's labia majora for the purpose of assessing or assisting with health management activities. Putting an instrument or finger beyond an artificial opening into the client's body for the purpose of assessing or assisting with health management activities. And it would be important that we recognize that many RPNs, again, depending on your setting, are if you have relevant competency, you have the capacity to do this effectively. You currently can, most of the time, again, depending on where you're working, perform those activities if you have an order. What is different here is that idea of initiation. Remember I talked about it on the last slide, is that you would go into a different kind of category where you would be able to independently determine if this activity needed to take place, and then be able to perform that without an order. All right, so it's the performance of a controlled act for which you are competent without an order. Keeping in mind, so now we know you most of the time can perform these if you have an order. The change in this regulation would mean that you could, under certain circumstances, perform them without an order. You could initiate this if it was deemed by you as a professional to be required, and if you were competent, right? If the legislation is changed, you could initiate this without an order if it was necessary and if you were competent, except, you know what still is the holdup, even if the legislation changed? Most of the time in hospitals, there are facility policies that may prevent you from doing some of these things. So additionally, you have to look at the terms of your hiring. Terms of your job can never expand beyond your scope of practice, right? They can never say you have to do these things that by law the College of Nurses has said you can't do. But terms of your job can further limit your scope of practice. So even if the College of Nurses says you can do a certain activity, your employer with the facility within which you work may say, no, RPNs are not going to be able to do that, only RNs, or RNs are not going to be able to do that, only nurse practitioners. So it's important that we recognize the changes here in these controlled acts are around initiation, not whether you can do them with an order, but if they are necessary and if you have the competence, you will, if the law is changed, have the authority to do them, as long as it's not contravened by hospital policy. And often within hospital settings where many of us work, there are really strong policies about what can and can't be done. But it's important to recognize it is an expansion of the RN scope of practice. And so fairly exciting as we look at how nursing is moving forward and recognizing the three different categories within one profession: RPN, RN, RNEC, or nurse practitioner. So within this three-factor model, let's come back to this. One of the other factors that we really want to talk about was nurses' accountability. And so how do we show accountability most often we think about that, it's that I am responsible for my own decisions and I am responsible for my own actions. Important that we take action when necessary, right? And always that we are looking again for the best possible outcome for the client, that we don't go beyond the standards of practice. Oh, I'm going to sneeze and I want to apologize. Excuse me, that we don't go beyond the standard of practice. Even if I think a patient needs immediate surgery, I can't do that. That is beyond the scope of my practice. And we can't go beyond legislation, right? And a key point of our accountability is that we're expected to consult with each other. So when you have a good work environment and there is a lot of collaboration that happens, we're able to talk with each other, learn from each other. It's so critical, not only because it creates a better work environment, we learn more, we progress more in our own professions, but also because it is essential to nurses' accountability. The expectation is in the law that we consult, right? We consult with other care providers, and that I'm accountable for my own actions. I'm also accountable for that consultation that takes place. I'm not accountable for other people's actions if I have no reason to know what they are, right? So what are we accountable for? Let's just talk about this briefly. My own actions. I need to know and understand. Do you remember we talked about roles at the beginning and the role conflict, role confusion? I need to know and understand the roles and responsibilities of those other team members. So Sue Coffey, time to look up OT and have a better understanding of, I know what the definition of an OT is, but I need to have a better understanding of how that person works within the team, don't I? That's my responsibility. We need to be able to collaborate and consult and take action based on the client information. And when we take action, it is always about patient safety, moving towards patient safety. If there are any concerns around conduct or action of any of the care providers, we would report those. And we're always taking into account those three things that are part of this three-factor model: the client, the nurse, and the environment. We'll talk more about those. Not only do we collaborate with each other, but we collaborate with the client. So critical that within the context of an interprofessional team, the client is also a member of that team. So when we look at a nursing authority within the context of CNO, the nursing authority is the nurse in any situation who has the highest level of authority for the practice environment, right? So that could be within a moment, a charge nurse. It could be the supervisor, a variety of persons, right? And it could be up to the director of nursing. And that person is accountable for ensuring that those mechanisms are there, policies, procedures, and guidelines that are able to support you. Now, if we're talking about policies and procedures for the entire hospital, that might be the director of nursing that's involved in that. If we're talking about unit-based policies and procedures that really affect the patients on your unit very specifically, it might be much more likely that the nurse manager is working to create those documents and have them approved so that you can work more effectively. If it's something like, not the policy, but the practice of something straightforward like handing off shift report, although often that's an organizational activity, but let's say it's shift report on your unit. It may be that the team leaders or charge nurses, if you don't have a rotating charge nurse, but a consistent charge nurse, come together and they decide they're going to try practice, they consult with the team. So depending on what we're looking at, how big or how relatively limited the activity is, the person with the greatest level of authority is responsible, holds that responsibility. It's important that all of these things are taken into account, the decisions, collaboration, and consultation take place, that everyone has clear and well understood role descriptions, that professional nursing practice happens, and that continuity of care within the context of the three-factor framework takes place. So all of those things, all of us are responsible for making sure those things happen. But the designated nursing authority, the person with the highest level of authority, so director of nursing for some activities, it might have some things maybe delegated, to the level of a nurse manager or something else, or a team leader. But that process would be very clear. And we would make sure that things aren't fuzzy. We don't know who's responsible. There's excellent clarity within the CNO documentation about who has the authority and the accountability. So let's talk about those 3 factors. Do you remember what they were? Client factors, nurse factors, environment factors, right? So the client factors, there's 3 of them. Complexity, and we talk about that a lot. Predictability, and we look at the risk for negative outcomes. In the old days, we used to determine whether a patient should go to an RN or an RPN based on sort of a simpler framework, but it wasn't as helpful, but it was simpler to understand. We used to say, look at whether a patient was stable and whether the care of that patient was predictable. Now we've moved to a little bit of a model with greater fluid decision-making, and that enables us to really understand all of the factors that go into making the decision about who's the best person to provide that care. So when we look at complexity, we want to know how easy is it for us to identify the care requirements of a patient? Do we know what a patient requires for care? And have those been established? So do you remember I talked a little bit earlier about whether a patient has a diagnosis or not? Has a patient's condition changed recently? So I'm not sure what's going to happen in the next short while with that patient. Is there something unknown about this patient? We may look at all of the variables that are part of a patient's health status. And that could be like physiological variables. It could be social variables. It could be psychological variables. There's a whole bunch of things. So all of those things that impact a person's health status, and how variable a client's condition is, or how variable the care requirements are. So a patient, we could expect that those orders will not change over the course of the day, that they are quite predictable, or we could expect that a patient, for example, whose blood pressure is being maintained by blood pressure support medications like dopamine or dobutamine, that that condition may be changing rapidly and their care requirements may change rapidly. We also look at predictability. And in predictability, what we focus on is the extent to which clients' outcomes can be anticipated. Can we likely predict what's going to happen? Now, we can't always predict. Something will surprise us all the time. A person is about to be discharged and they, drop and have a heart attack on the way out the front door. We can't always predict that, but we try to determine what is the likelihood that we can anticipate a patient's care requirements, and that's around predictability. And then finally, what is the risk of a negative outcome for that patient? So what's the likelihood that the patient might have a negative outcome based on their condition? So what is the likelihood that a patient would have a negative outcome? So they could have some disability, debilitating lifelong or longer term condition, or they could die. So what is the likelihood that they could experience a negative outcome as a result of their health condition? Okay, or as a result of response to treatment, how risky might a treatment be? So client factors are 3: complexity, predictability, and risk of negative outcomes, right? Complexity, predictability, and risk of negative outcomes. Oh my gosh, the wall of words again. But I just want to talk about nurse factors, and I want to be precise about this because for us, this is our bread and butter. This is about how we keep ourselves safe by ensuring we are following our own role expectations. So when we talk about those nurse factors, those are all of the factors that affect our ability to provide safe and ethical care to any given client. And those include things like leadership, decision-making, and critical thinking skills. And so it's not a surprise that in this course, we're talking about leadership, we're talking about critical thinking skills, and within that context, decision-making. So other factors, and those are taken right out of the standards of practice, are things like application of knowledge, or knowing when and how we apply our knowledge. So it's not good enough that I learned all of this in school and I have it in my head. I also need to be able to recognize the situations in which I apply that knowledge and in what way I apply that knowledge. And also that I have the resources that I need to be able to do that. we also need to be able to recognize the limitations of our own competence, right? And do you remember I said not every nurse knows everything, and not all of us fill the entire scope of practice, but all of us together, the entire profession is defined by that scope of practice. So I'm an emergency nurse, and I love everything about emergency nursing, adult and pediatric, and specialize in shock trauma, and have a long background of being able to do that. You know what where I would say I have a practice gap, and I don't feel terribly bad about that, because in an environment where I would choose to work, I would make some choices about how I would be involved. I am not the best person to deliver a baby. I have the basic knowledge and skill, but many people are much more adept. It is not typically within the scope of within my role as an emergency nurse, because typically there is a labor and delivery floor upstairs. I worked in the United States in a community-based hospital that did not have a labor and delivery floor, and so had to be involved in delivery of neonates, and it was not my favorite thing to do. I certainly made sure I had the competencies. It continues not to be my favorite thing to do. And I bet some of you work in labor and delivery and love it, and I am so appreciative of you, but it's not my strength. Each one of us has to know that about themselves, right? So if somebody were to say, oh my gosh, there's a person in the lobby who's in active labor, I'm afraid we're not going to get her up to the labor and delivery floor. I would not say, let me go help her. If there was no one to help her, I would, absolutely. And I make sure that I have that skill, because sometimes that might happen in the ER. But I might be able to say, I've got your patients, you go. Like if you've got the skill, go. So I would take part in that by transferring the accountability of other patients to me. So I would really self-assess. Does that make sense to you? All of us know where we have strengths and where we don't. Within the context of that, we also know how we need to build our strengths within our own job, right? Within our own role performance. Not every nurse needs to know everything. And we need to know what is required in order to provide safe, competent, and ethical care within the context of our role, and we need to be able to consult. When the situation demands it, we need to consult with each other. This consultation is a really big thing. And so always there's going to be moments where we move beyond our own level of competence, and so we need to seek advice, right? I seek advice from another nurse. That may be someone who's more experienced in terms of years, someone who has more knowledge because they went to school to a higher level, someone who has maybe even graduated sooner, so they have learned new ways of doing something. It may be a different kind of health professional. So sometimes it's a professional with the same designation as me, sometimes it's a different health professional, and for different reasons. And the amount that I need to consult, not a surprise, is determined by how complex the patient care needs are. So how complex the patient care needs are, and also the gap. So what is my own level of competency? If I just want to check one thing, example, do you pre-inflate balloons anymore before you insert a Foley catheter? Do you? Answer, you all know it. No. Lots of nurses still do. Do you ever go on practice settings and nurses still do it? Some people argue that there's no harm. Lots of people argue there is harm, because as you inflate that balloon, you increase the level of friction in inserting that Foley catheter. But let's say I'm not sure, I might consult with it. I could look at a policy on the system. I may consult with another nurse in that organization to see if she or he knows if they have a policy. That's a narrow, right? That's a narrow consultation. Might be a much broader consultation when I'm looking after a patient with a condition that is beyond what I typically look after, and I don't have the greatest understanding of what those care requirements may be, and if I possess the competency to take part in that care. And it's important that we recognize that within our practice setting, that consultation is essential, and that the practice environment has the responsibility to create opportunity for you to take part in that consultation. So the practice environment, your hospital, your community health providing company, they are required to create an opportunity that you can consult as needed. That is the backbone of our practice, the expectation that we consult. It's not good enough to say there was nobody to ask. The expectation is that the organization, your employer, provides an opportunity for that to happen, whether it's by staffing ratios, creating a role, all kinds of ways that they can do that. And if that is not available, that they rectify that. So you would speak out if there's no opportunity for consultation. A couple of things to keep in mind. Unless you have transferred care, right, transfer of accountability, unless you've transferred care, even if you seek consultation about something, you are still responsible for your client's care. Even if you seek consultation about how you would do something, or what does, let's say I'm not certain about these vital signs, do these vital signs seem to fit with this clinical picture for you, and you get some consultation, you are still responsible. And that means that the consultation is advice, but you still need to make sense of that, don't you? And consultation, the point of consultation is that it results in one of the following things. Sometimes you get advice and you can carry on, right? I want to take part in this procedure. I haven't done this before. I know I learned it in school, but I haven't done it on a person, blah, blah, blah. You may work it through, you may get some advice, you may be able to carry on with that. Or you can transfer one aspect of care to the consultant. So for example, we come back to, I learned about inserting an NG tube in school, but I've never done it on a real person. Would you be able to help me with the insertion of that NG tube by doing it one time so I could watch? A better option in this case might be that could I do it while you watch me, but if you're not ready, that might be an example. So you transfer one part of care to the person you're consulting with, or ultimately you transfer all of the care. So as a result of this consultation, remember, you are responsible, even though you've done consultation, you are responsible for care unless you've transferred care, officially transferred care. So you can't say, well, someone told me that. Unless you've transferred care to that RN, you are responsible. And so the person who's receiving advice, if you're getting advice, you can continue to provide care. You can transfer just a portion of care to someone else, or you can transfer all of the care to another person. When you transfer care to another person, you transfer accountability. And that's why transfer of accountability is really so important that we use that phrase. So if someone else then begins to look after that patient or is doing a procedure, they are responsible for that. They are accountable for what they are doing. And we make it clear that you are transferring that accountability. When there are not enough environmental supports, right? When there are not enough environmental supports for you to be able to consult as necessary, you need to take action. That might be going to your nurse educator, going to the nurse manager. It might mean a whole bunch of different things. But as a nurse, if you recognize there are not opportunities for you to consult, then it's really critical that you go and seek a resolution to that, instead of just saying, throwing your hands up and saying, well, it's too bad. I know the organization never supports us. Okay, so we talked about client factors. Do you remember what those were? Complexity, predictability, and the risk of a negative outcome. We talked about nurse factors, and there's a lot, right? And a big thing we talk about there is around consultation. Remember, scope of practice is the whole profession, and I work to my greatest capacity within the broad scope. But I also have to have self-awareness of my own limitations, and I take part in consultation, which is an absolute necessity within our profession. And I then look to make the determination of whether transfer of care is required or not. And when we transfer care, we transfer accountability. And now finally we go to the environment. And so what is necessary in the environment? This is why this 3-factor framework is so essential. It's not just whether I'm a good nurse and I can do everything. It also looks at the situation with the client, but also the organization where I'm working. So the responsibility can't all fall to the nurse. So when we look at environmental factors, we look at, are there practice supports, right? So is there education, on-site education that enables you to continue to learn? Is there enough adequate staffing, things like that? You look at consultation resources, we talked already about that, but the ability to consult, are there enough staff to be able to do it? Are there people who are very specifically within those roles? So you might have a unit-based educator who's able to provide consultation in the moment, or you might staffing requirements or staffing patterns may show a charge nurse or a team leader for that day. And also the stability or the predictability of the environment. And this is where we sometimes look to those higher acuity units. And the question is what is the best staffing ratio for something like an ER or a trauma unit? And it's really important that we recognize the less available those supports are, practice supports, consultation supports, the greater the need for higher level nursing competencies and critical thinking and leadership and management of resources. And likely the greater need for RN staffing. Okay, so the less available those practice supports, consultation resources are, the more likely you're going to need RN versus RPN staffing. So important when we recognize the environment. Okay, and now it feels like we've gone on forever. I am not going to go through everything about standards of practice. I've listed the standards. These have not changed. You've got a document. Am I going to expect you to memorize all those standards of practice? No. But what I would expect you to do is take a look at the statement that describes accountability, continuing competence, ethics, knowledge application, leadership, relationships, and professional relationships. So look at the summary statements that describe those and have a good understanding of what that means. Okay, so within that reading, I don't expect you to memorize those standards of practice and all the different, you know, as a nurse or as an educator, as a researcher, as other things. Just understand from the description what that means. Okay, and then finally, the entry to practice competencies. You'll see this as you work your way through the program more and more, because as you do your next clinical in the summer of next year, and then the following summer in community, and then in your last year in your synthesis course and your final integrated practicum, the document that we're using to do our clinical evaluations is actually based on these entry to practice competencies. And there's a new model for the entry to practice competencies that has just gone live this month, or yeah, September of 2020. And what they've done is really brought the competencies together into 9 roles. So 9 RN roles in the entry to practice competencies. And those roles are, so all RNs fit within these roles, enact all of these roles. So how do you enact the role of a clinician? And the entry to practice competencies list the kinds of things that you do to enact the role of clinician. How do you enact the role of professional competencies? How do you enact the role of communicator competencies? How do you enact the role of collaborator competencies? How do you enact the role of coordinator competencies? Leader, advocate, educator, scholar, all of those things. So there's 9 roles. So first of all, not every nurse meets all of those competencies. Those are entry to practice competencies. Through the duration of your program, you will demonstrate you have met all of those competencies. They're necessary in order to meet, but that doesn't mean you meet them every day in your own practice, right? So some competencies may be specific to settings like mental health setting or a community-based setting. And if you're working in an inpatient labor and delivery unit. So you may not be meeting those competencies, but over the course of your program, you have an opportunity to have met all of those competencies. And within the program, we need to show that you have met those, that that's included in the curriculum. What I would like you to do is take a look. I'm just going to share my screen here. So take a look at each one of those competencies. So see along, do you think I want you to know this? No, 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 no. We don't need definition of client. You don't need to memorize all that, right? So it feels like a big wall of words. Here's the picture, and it talks about all of those 9 competencies, right? And this is the model by which they look at it within the College of Nurse. The registered nurse enacts all 9 of those roles, not all at the same time, but you're able to enact all 9 of those roles. And then what I'd like you to do is just, you don't have to memorize it. You're going to recognize this, but I want you to read the description of that role. So let's look at the role of the clinician. Registered nurses are clinicians who provide safe, competent, ethical, compassionate, and evidence-informed care across the lifespan in response to client needs. It's a pretty good statement, right? Registered nurses integrate knowledge, skills, judgment, and professional values from nursing and other diverse sources into their practice. And there are many competencies that are listed beyond here, right? And so I would not in a million years ask you to memorize those. I am not going to say, is 1.17 incorporates knowledge of epidemiological principles into plans of care. I'm not going to, check to see what role does that fall within, right? I just want you to have an understanding of what is the role of a clinician, and does that make sense? Let's look at professional. Registered nurses are professionals who are committed to the health and well-being of clients. Registered nurses uphold the profession's practice standards and ethics and are accountable to the public and the profession. That makes sense, doesn't it? Of course, we're accountable to the public and the profession. Communicator. Registered nurses are communicators who use a variety of strategies and relevant technologies to create and maintain professional relationships, to share information, and to foster therapeutic environments. That makes sense, doesn't it? And then all those competencies describe that. Collaborators, even shorter. Registered nurses are collaborators who play an integral role in the healthcare team partnership. Perfect. Coordinator. Registered nurses coordinate point of care health service delivery with clients, the healthcare team, and other sectors to ensure continuous safe care. Central to what we do is to be able to collaborate with not only our patients, but other members of the healthcare team and potentially other sectors. Let's see, before I get to advocate, what do I have? Leader. Registered nurses are leaders who influence and inspire others to achieve optimal health outcomes for all. And I know that you guys are leaders. Advocate. Registered nurses are advocates who support clients to voice their needs to achieve optimal health outcomes. Registered nurses also support clients who cannot advocate for themselves. Let's see, where are we? 8, educator. Registered nurses are educators who identify learning needs with clients and apply a broad range of educational strategies towards achieving optimal health outcomes. And then finally, scholar. Registered nurses are scholars who demonstrate a lifelong commitment to excellence in practice through critical inquiry, continuous learning, application of evidence to practice, and supportive research activities. Critical, right? So, and even that, I don't expect you to memorize these descriptions. It's just important that you understand what all of those roles are, because you are expected through the course of your program to demonstrate that you have met the competencies to meet all 9 of these roles. All right, so all 9 of those roles: clinician, professional, communicator, collaborator, coordinator, leader, advocate, educator, scholar. And over the next 3 years, that's what you're going to be demonstrating, the competencies that enable you to be able to say you have met those role requirements. And phew, another one's done. I hope that was helpful. I know, do you remember at the beginning, I was hoping that it was very particular without being too tedious. It was very precise without being too tedious. And I'm not sure if I got there, but I sure hope I did, or I did my best. But you've got readings for this week. You've got a copy of those entry to practice competencies. Remember, you're looking at roles, just the roles. You've got those practice standards. I'm not expecting you to look at everything. I want you to just understand the basis of those standards, right? What are those categories that we're looking at? And we did talk a lot about that 3-factor framework. It's important you understand that, and you understand that within the concept of roles within our practice, our own role, understanding others' roles, and our responsibilities within the context of our RPN or RN designation. Well, I look forward to the next time that we have an opportunity to get together, but for now I'll say goodbye at the end of this presentation, and I hope you have an opportunity to, that we have an opportunity to meet, have a cup of tea or have a cup of coffee, and talk more about RN roles and RN responsibilities.